Okay, this is a very esoteric topic, and I don't know whether I'll be able to wake you up from your afternoon slumber. But important thing in critical care medicine, you must remember, unlike any other branch of medicine, is there is a thinking concept which is slightly different. A doctor has, most doctors think in three ways. One is objective thinking, one is abstract thinking, and a third is lateral thinking. But lateral thinking comes more often in critical care medicine. It does not come so often in your routine day-to-day medicine, because there where objective thinking comes in. Objective thinking is your knowledge that you learn from your books. It is your protocols, your guidelines, is what your teachers tell you about it. So these are the objective things that you learn. Abstract is the spiritual part of it, whether we should do euthanasia, whether there are no guidelines, there are no numbers there. Nobody is going to have numbers for euthanasia. There are no numbers for DNR, neither for cost effectiveness. Yes, cost effectiveness and cost benefit, there are numbers in America, in Western countries, because those are the places insurance company dictates. Over here, the person dictates himself. Your relative dictates. The relative will say, I don't care. I've got the money. I've worked so hard all my life. Even if my father is going to live for another 8 months with malignancy or whatever you call it, I want that life. And you'll put him on a ventilator. You'll put it on this. So that's what is called abstract thinking over here. But an intensivist has another problem. And most of the intensive care, I'm telling you, most of you, the budding intensivists, have to learn medicine at the bedside. No critical care medicine can ever be learned in the library or on your computer. They are good to amass some knowledge, but basically you have to develop what you call thinking out of the box and lateral thinking. And this is what we are going to talk about. If patient, you must have seen so often in your ICU, you walk into the, you have a patient who is critically ill, but he has been stabilized. His PF ratio now is stabilized to a certain level. His inotropes and vasopressors, whatever is receiving, the dose is not going up. As a matter of fact, you think it is now being tapered off slowly. Everything is going fine. His FiO2, you are bringing it down. Everything seems to be honky-dory at that present moment, and you go out and tell the relative, fine, sab acha hai, everything is going well. Now you don't have to worry, I think everything is going extremely well. And he, of course, does everything that makes you feel like a demigod. Next morning, you come there, and your husband phones you, tells you, so things are bad. Vasopressor dose has gone up. Blood pressure has fallen drastically. His FiO2 is now again 100%. And of course, you don't know how to face the relative after that. You go with a poker face and look in front of him. And you don't know what to tell him. But it's not always the decline of the same disease. More often than not, it could be, and you have experienced it. It could be some another cause, an unexplained cause. And that's what I want to talk about. An unknown cause, how to pick it up. And that you'll only get to know if you take rounds at the bedside, day in and day out. Only if you look at patients. Only after looking at patients, you'll know what is the Hippocratic faces. Only if you look at a patient, you'll know why the patient puts on a fan in an air-conditioned ICU, because there is air hunger. Those are the things that has to be picked up by an intensivist. Rest of the things, yes, you can learn from your books. So we go further on. Where is the thing to go forward? I can use this. This one?
Yes.
Okay. Okay. Starting at it, any kind of a disaster or catastrophe that is going to occur will always, whether it is, it always begin with a respiratory dysfunction or cardiac dysfunction. And the end result, which comes down and percolates down, is bound to be either hypoxia or dysoxygenation or fall in blood pressure and shock. And the surrogates for hypoxia could be breathlessness, could be fighting the ventilator, or could be requiring more FiO2 for that patient. So those are the surrogates of breathlessness, for hypoxia. So these are going to be conundrums, and I will be taking as case scenarios. I'm not going to give you detailed cases, just the case scenarios, because we have to go fast. Prachi doesn't give us, she's not very charitable in giving us long times to talk. Oh. So scenario 1, this is my old case, and I always start with this because this was something which I discussed with so many of my residents, and always I get different answers. A 60-year-old male patient with a past history of myocardial infarction, pre-op left ventricular ejection fraction was 45% with a normal ECG. Exploratory laparoscopy for mass in descending colon he was taken up for. Episodes, suddenly he had an episode during the theatre, just before they could open up, and just before the anesthetist could start the surgery. The patient developed a fast atrial fibrillation with a rate-related bundle branch block, with a fall of blood pressure to 80 during the time of intubation. After delay of 30 minutes and a cardiac consultation, the atrial fibrillation returned to sinus rhythm and became a normal QRS, and that was after a bolus of IV amiodarone given by the cardiologist. Surgery commenced with amiodarone drip, mass resected, and colostomy was done. Now, in the operation theatre, everything was going extremely well, so extubated in the operation theatre, transferred to the ICU for observation with the amiodarone drip in progress. When the patient was received in the ICU, the nurse concerned, the receiving nurse, found that the blood pressure was 80, so the heart rate was 130 per minute, respiratory rate was 34, temperature was slightly low, 96 degrees, SpO2 was 80%, on 6 liters of oxygen, chest was clear when the houseman was called immediately, or the resident intensivist, and he found the chest was clear. He asked for urine output, and at least there was nothing in the bag, and neurologically normal, but peripheries were icy cold. Now, so what is the first thing that you will think about? Forget doing anything. This is what you see when the patient first comes in. This is exactly what you see. You are not going to get your echo immediately or anything of that sort. So what's the first thing one would think about? Do you think this is cardiogenic shock? Is it hemorrhagic shock? Is it septic shock? Pulmonary embolism? Hypothermia? Anything could fit in. And so often people have told me, most of the people obviously say it is cardiogenic shock. This patient had a cardiac problem, he had a fall in blood pressure, he had an atrial fibrillation, he must be having an underlying ischemic heart disease, and this could be cardiogenic shock. Some people say, no, but I can't talk anything, I cannot say anything. Some of the doctors told me, until I get more parameters, how do I know it is not hemorrhagic? I want to know hemoglobin. So fine. So next thing what we did was get his CBC done, ECG done, echo. Those are the fastest things that you could do. Now the hemoglobin shows that there was a drop of 2 grams %. Echo showed nothing much, just unchanged echo from what it was before surgery. That is 45% ejection fraction, nothing else. Echo was perfectly okay. And ECG showed once again a rate-related bundle branch block, RBBB. Now where do we go from this? Now this is what it is. Now what I want to tell you is, every time you don't have to look for a diagnosis. Every time you have to see that you salvage the patient. That is more important. So what is the first thing to do in this patient? Let us look at it. You've done an echo, fine. So you rule out a pulmonary embolism because there is no right ventricular dysfunction. And a person with pulmonary embolism goes into shock, has to have a right ventricular dysfunction. So your mind is clear, that is not there. Yes, 96 degrees Fahrenheit is not going to give you this picture as a hypothermia. Obvious. And the question comes out, hemorrhagic shock, 2 grams is not really much. It may be dilutional. They must have given fluids and whatnot. 2 grams is not going to give. So I always go by one dictum. These are the 3 things cannot be possible. So when you rule out the impossible, whatever remaining, however improbable, is the diagnosis. So diagnosis has to now rest between cardiogenic and septic shock. But do I have to know what it is? For cardiogenic shock or septic shock, the resuscitation is going to be the same. But there is only one thing that you can miss out. And that is, if you do not give antibiotics appropriately and in time, you miss the bus. So think laterally and say, okay, it could turn out to be cardiogenic, but I am going to think about septic shock. Very often the residents tell me, but why sepsis? Why should that infection occur in the theatre? One of the reasons is that you must remember the patient has a hypertension in the operation theatre. And that's the time, what happened? Sudden translocation of bacteria into the bloodstream, because the gut integrity was compromised at that time. And that's why probably sepsis could have occurred. And that logical thinking brings to the fact that yes, I must cover him with a broad spectrum antibiotic first thing over and above the resuscitation. And that helps. This is the kind of lateral thinking you all should possess. Of course, if you phone up the operation theatre and say how long the patient, I did it. How long did the patient was hypotensive? The anesthetist told me, the nurse of course was very diffident. She put it onto the anesthetist, and anesthetist told me just a minute or two. I said, okay, the cardiologist must be the Milkha Singh to come so fast. Second scenario, an obese patient with decreased LV function, mildly raised creatinine, recovering from septic shock. This is what you see all the time in the ICU, but we don't think about it much. Recovering from the septic shock, mean from mechanical ventilation, suddenly deteriorates, requiring re-intubation. Mechanical ventilation and vasopressors. No change in ECG, 2D echo, and new shadows on XHS. No new shadows on XHS. No fever, no significant change in the WBC count. Now, what could it be? Is it a new infection? Is it a cardiac failure? Or is it a pulmonary embolism once again? This is what are the kinds of scenarios that you do. And you don't know what this could be. New infection, because how do you find out there's a new infection? You cannot make out. As you already earlier lectures told you that your procalcitonin is not going to be very helpful post-operative in a patient who has got a creatinine which is raised. So it may not give you that exact thing. So you don't know what you're dealing with. Anyway, what are the useful things at this moment in time to find out would be, once again, think about it laterally. What can I use, the most useful thing at this moment? Procalcitonin is not going to be useful. Blood cultures are not going to come immediately. So what am I going to do now? Best thing is the use of a thing like an echocardiography. Of course, I may be wrong what I am looking at, but I am just giving you an idea to tell you that how you can think laterally, you can think of something else. But this is where I thought, okay, if it is pulmonary embolism, we'll rule out the pulmonary embolism. There's no RV dysfunction. And I will, most important, what I want to do this patient just now is whether to give him fluid overload or not, whether to give him volume challenge or not to get his blood thing. I may put this patient once again into pulmonary edema, or patient may remain hypovolemic and I will have a problem. So echo also tells you about IVC compressibility. I'm not going to go into details of that. That has been explained. And this is the IVC compressibility, as you see over here. Sorry. So it gives you the idea whether fluid challenge should be given or not. It also tells you whether there is right-sided problem. It also tells you whether there is a cardiogenic problem, there is a regional hypokinesia, or any of those things. So this is once again how you think. Your thought process should be in this direction. Okay, this is very often you see bypass patient, wean from mechanical ventilation. There is a bravado with most cardiac surgeons that some of them say, oh, I extubate my patient in the recovery room itself. Now, needs re-intubation, mechanical ventilation the very night when he was extubated. What do you think about? Think about, always remember one thing. He has been on a ventilator. He's a cardiac patient. Ventilator, what does it do? With positive ventilation, it pushes the fluid out from the alveoli into the bloodstream all the time. You all of a sudden withdraw him from the ventilator. And if he has got subtle or cryptic pulmonary edema, it will come back from the vessels back into the lung. And you can see it on this CT scan, the features of interstitial pulmonary edema. You see ground glassing over there. You see interlobular septum thickened. In this patient, I'm sorry, I don't have a pointer. There it is. Anyway, so this is one thing you should think of. A bypass patient, when it is withdrawn from a ventilator, all of a sudden, this is something, the interlobular septa, and there is a ground glassing all over. So this patient has gone into pulmonary edema. So put him back on the ventilator. Get him back or put him on a BiPAP and see that you give him positive pressure all over again. Patient of ARDS stable on mechanical ventilation on a FiO2 of 0.4, suddenly fighting the ventilator and requires sedation. Relaxants and increasing FiO2 to 80%. What is the cause? This is a patient of ARDS. Stable on mechanical ventilation, going on like that, suddenly starts fighting. All of a sudden, you just can't do anything. He keeps fighting the ventilator. What do? You start giving more sedation, relaxants, and just be happy about it. think immediately of a pneumothorax. Very important thing to think about. Any patient on a ventilator suddenly deteriorates. First, see that ventilator settings and the tubings are okay. Next, pneumothorax is a very, very important thing. Next, what do you see in this ECG? He has not developed anti-wall infarction. This is a mimic. His left lung and the pneumothorax, so the R waves disappeared. As soon as we put a T-piece, an intercostal thing, R waves came up. So even from an ECG, you could have detected that. Then the other thing is cardiac tamponade can occur. So many such things can occur. So when a patient suddenly deteriorates like this, think about this any acute deterioration like that. All of a sudden, patient starts fighting the ventilator, becomes tachypnic, or needs higher FiO2. Think about pneumothorax, very common thing to think about. And think about pulmonary embolism. That's the other thing that you can think about suddenly happening, or think about cardiac tamponade. But first and foremost, see your settings are okay. Your respirator settings, ventilator settings, and your tubings are well connected. ARDS patient deteriorates with increasing lung shadows and decreased left ventricular ejection fraction. Now what do we do? You see so often patient is with ARDS, you're looking after him, and then suddenly the resident tells me, but there are more lung shadows increasing over here. So has he gone into pulmonary edema? Has he gone into pulmonary edema because his LVAF is low? I don't know his previous LVAF. He has got no signs of infection. What should I do? Start treating him as that pulmonary edema altogether? Well, we all depend upon BNP, your natriuretic peptides. They are of two types. This is useful. BNP is useful if you know how to use it. And that's why I'm going to take 2 or 3 slides to let you know something about the BNP. BNP has 2 components. One is what is called BNP and one is NT-proBNP. The BNP has got a shorter half-life of 20 minutes. The NT-proBNP has got a half-life of 60 to 120 minutes. The reason for that is NT-proBNP is totally excreted by the kidney, whereas the BNP itself is reduced by the receptor cells to a great extent. And that's why its half-life is much shorter. So in patients with kidney failure or kidney problem, your NT-proBNP will be always higher and may give you a false reading, and BNP will be a little more specific in these conditions. This is down below is given to you the normals of BNP and anti-BNP that we should in chronic conditions and in acute conditions. The predictive value of BNP differentiating congestive heart failure from pulmonary causes of dyspnea. BNP less than 100 and more than 500 have a 90% negative predictive value and positive predictive value respectively. Intermediate levels between 100 and 500 rule out effects of GFR less than 60 ml per minute, rule out RV dysfunction in COPD, rule out cor pulmonale and pulmonary embolism. Intermediate levels plus 2 or more clinical intermediate levels once again between 100 and 500 plus 2 or more clinical features of CHF plus relevant past history increases the predictive value of acute exacerbation of CHF, and intermediate levels may be seen in patients with echo findings of low LVEF or valvular heart disease but without overt signs of CHF. So that has also been observed. It correlates extremely well with your NYHA grading and also with your evidence of LV function. NT-proBNP and BNP are both affected in renal function, but NT-proBNP is slightly more affected. NT-proBNP is useful in detecting covert CHF because it's very sensitive. If there is a covert congestive heart failure, it is detected very fast. Always remember, obesity gives you wrong results. If the patient is obese, especially with a BMI more than 30 kilograms per square meter, will have a lower NP value, and you have to take that into consideration. More important, natriuretic peptides may be used to diagnose congestive heart failure due to diastolic dysfunction. That means preserved systolic function, but a diastolic dysfunction. But cutoff points need to be age adjusted because higher the age, the cutoff point starts becoming different. Not useful in diagnosing AMI or acute coronary syndrome or pulmonary embolism, but useful for risk stratification in confirmed cases of these 3 entities. Natriuretic peptides have a strong negative predictive value. Persistent elevation despite treatment strongly suggests resistance to treatment. These are the usefulness of your BNP and proBNP. The next scenario, I'm going to go fast because we want to show some of them. Female patient repeatedly admitted with fever and flash pulmonary edema and increased BNP with no specific changes in ECG, normal LVF and normal coronary angiography. I see these patients quite often, especially female patients. They just come, nothing. They come in pulmonary edema, but you do the angio, it is normal. You do the ECG, it is normal. You do everything, it is normal at that second particular. The two entities you should think about if such a thing happens. One is my patient who had we did a telemetry after she was discharged because we couldn't understand. She was in sinus rhythm, everything went all right. By the time the EMS had given Lasix, she became perfectly okay. But the X-ray did show pulmonary edema. She became all right within 48 hours. The relatives said, we want to take her. I said, no, please, I can't understand. We have done her angio, everything, it's normal. It's repeatedly happening. Get her out of 24 hours ambulatory monitoring. And suddenly, we picked up on ambulatory monitoring. We found there was atrial fibrillation. So, paroxysmal atrial fibrillation can sometimes put a patient into pulmonary edema. So, don't just disregard it and think about she must be having coronary spasm, this, that and all. Just think about it, paroxysmal atrial fibrillation. This was one of our cases that was there. The more important thing is preserved systolic function, heart failure with a preserved systolic function, in short answer, diastolic dysfunction. Women have a higher incidence of diastolic dysfunction, and patients with diastolic dysfunction, especially a high, moderate degree of diastolic dysfunction, can keep coming repeatedly to the ICU with pulmonary edema, with normal angios, all other parameters absolutely normal, and left ventricular ejection fraction being 50-55 normal. So please keep this in mind. Another thing is this was a patient coming in with unilateral pulmonary edema. When you get a patient like this coming with a unilateral pulmonary edema, you do not understand what are we dealing with a unilateral pulmonary edema. Why does it happen repeatedly unilateral? COPDs, when they get pulmonary edema, can get unilateral pulmonary edemas. Of course, the other problems are when a patient has got a pacemaker, Swan-Ganz catheter balloon in one pulmonary artery and kept inflated, gets pulmonary edema, will have a unilateral pulmonary edema. A patient with massive pulmonary embolism can have a unilateral pulmonary edema. Patient admitted with clinical suspicion of unstable angina but normal ECG suddenly becomes breathless with following ECG. What do we think of? You get this ECG. What do you think about? You were given a thrombolytic therapy. Straight away, this patient had a intracerebral hemorrhage. And that's the reason for monumental T waves that you see in anterior wall. You are given thrombolytic therapy and disaster could have started. This is another thing that happens to another patient. Okay, I don't think everyone in the back seat will be able to see. Patient came the same way. We thought it was anterior wall infarction. If you can see, I can show you. There is no R wave at all. There's picture of anterior wall infarction. Here the resident gave a thrombolytic therapy, but he was lucky because immediately the patient's R waves came up within minutes. And the resident told me, I gave thrombolytic therapy, he recovered, coronary artery, everything has opened up. But when we investigated later, it was a pulmonary embolism. Pulmonary embolism can have a transient RBBB or incomplete RBBB or S1 T3Q3 syndrome. Developed sepsis on vasopressors and mechanical ventilation, post-expiratory laparotomy, perforated diverticulitis, partial colectomy done and colostomy was done. On midazolam infusion, 4 days later becomes drowsy, agitated. Each time sedation is decreased. Normal tendencies increase the sedation. Try to give more of muscle relaxants. No. Always take a history done. Either we do that and call a neurologist to assess the case, but I think an intensive care person should do some neurological examination. And in such instances, the best neurological examination is according to this list. Ask for a history of pre-admission, function, cognitive level of the patient, alcoholic history, alcohol and any other medications preoperatively. Ask for intra post-operative hypoxia. Intraoperative hypoxia difficult to get. Nobody will really accept it in the operation theatre. Everybody will say no. In saturation always 99-100%. So I think so. You'll have to be smart enough to catch some nurse and indirectly find out from how that was. Did the oxygen fall down in the theatre? Brainstem or lateralizing signs should be examined very carefully. Subtle manifestations of seizures, such as absent attacks, absent seizures with eye movements, eye rotation, upward eye rotation, which is extremely important that you should see. Signs of meningitis should be looked for. Extreme whole body rigidity with hyperpyrexia, which you see in malignant hyperpyrexia. Multifocal clonus you can see in patients who have got uremia, and asterexis in patients who have got liver disease. Investigations, a metabolic panel should always be sent. Arterial blood gases should be sent. Serum lactate should be done always. Brain imaging only if lateralizing signs or brainstem signs are there. CSF if there is unexplained fever or there is sepsis or meningeal signs. EEG should be done if abnormal eye movements, as I told you, upward rotating movements of the eye are there, or staring and not tracking the finger. Absent attacks occur with the patient, just keep staring at you, you will not be able to track the fingers. So this is one of the things where you can ask for EEG, or there is an unexplained coma. This is a case of Dr. Shruti Tendon. I hope she's in the audience today. And she had gone out of town, and she was looking after the patient, of course. And this was bilateral pulmonary edema that was detected. The ultrasound showed that the left-sided fluid was much more than the right-sided, and almost 500 or plus. Now, we did not see this properly at that particular moment in time, only when we retrospectively saw the ECGs. But this is what happened one fine day, all of a sudden. And what we saw was that we did ultrasound, and they said massive pulmonary, I'm sorry, it was pleural. The patient had massive pleural effusion. The patient has got a massive pleural effusion. Only thing is the patient has got massive pleural effusion. We got thinking, why? It filled up in 3 hours. It was a massive pleural effusion. We just couldn't understand what it was. And which line? I can't. There was a massive pleural effusion, central line.
It's on the left side.
On the left. Anyway, the most remarkable thing over here, can anyone tell me? It's a massive pulmonary edema. Well, correct. Why has the mediastinum shifted to the side of the pleural effusion? It should have been on the opposite side with a massive. And then we thought that the possibility of a mucus plugging. So Dr. Shruti asked for someone to do a endoscopy, and they took out the mucus plug, and I cannot show you that X-ray, I don't think I have it with me. Immediately everything opened up and totally. So the CT scan did show that there was a massive pleural effusion, but it was really not so massive. What was the whole thing was a collapse going to one side.
But why would it fill so fast?
Fill up in 3 hours with a mucus plug.
Nothing. We thought it was a white X-ray. What we are trying to put at is it was not pleural effusion so much. It was, that's right, but that it could be wrong, that's what I'm trying to say. It was, because the ultrasonography can show you something like that, but common sense says, why did it shift? Why was the whole mediastinum shifted towards the side of a pleural effusion? So that's why Shruti asked for a mucus plug to be removed from the thing.
I was out of town, you picked it up and you asked me.
I can't remember that.
You called me up and said, don't worry, I figured it out.
So anyway, but now if you look at it, we missed it earlier also. There must have been mucus plugging. If you see the mediastinum a little bit to the left side, it could be because it was not centered properly. But when I looked up the other X-rays, all the other X-rays, they all showed that the mediastinum was towards the left side. So there must have been collapse which we are not picking up on ultrasound, and the CT guys were just talking about the pleural effusions. Okay, just to summarize, history and clinical examination are extremely important, which I already told you about. Usefulness of bedside tests in diagnosis of acute deterioration. X-ray chest always useful in pneumothorax, lung collapse, pleural effusion in pneumothorax. ECG for obvious reasons that you see over here. Arterial blood gases more useful. You got your SpO2. Why do you want arterial blood gases to be done all the time? But very useful to know the PaCO2 level. PaCO2 is an extremely useful variable which you have to know in your intensive care unit. Biomarkers, these are the biomarkers. Some are useful, some are not useful. I cannot go over here, but I told you about the BNP and the anti-pro-BNP. 2D echo, most useful for Pulmonary embolism, as I told you, because of RV dysfunction, it will show if the patient is in shock. LV function and pericardial tamponade. Specific clinical settings in which 2D echo helps. As you see over here, in hypertension, it shows IVC collapsibility index is important. Congestive heart failure, IVC collapsibility once again is very helpful. Diastolic dysfunction, regional wall movements. In sepsis, once again same thing, IVC, LV function and endocarditis. It is very helpful to see if there is anything to do with endocarditis. If transthoracic does not give you anything, and if you strongly suspect, do a TE. Pulmonary embolism, RV function and pulmonary artery pressure by Doppler. Cardiac tamponade, pericardial effusion, RV diastolic collapse and IVC collapsibility once again. And if it is a prosthetic valve dysfunction, you can get transvalvular gradient. So many things you can learn from a 2D echo. And what someone, the previous speaker, talked about, every intensivist should know those 4 points of an echo. It's very important. I think every intensivist today should be able to handle echo, at least in emergency situations. So with this, I hope I've been able to tell you something around the rounds.